that again is sort of the barrier between the upper and the lower of the two respiratory tracts. Once we get to the lower respiratory tract, again, main stem bronchi branches out into smaller and smaller bronchi, which eventually become bronchioles, and then down into the alveoli, which are your air sacs. So it can be simple as saying that it is airways, versus airspace. The airways are conducting. That's what puts the air through your system. The airspace is where the business takes place. That's where the gas exchange actually happens and where diffusion of gases actually take place. So this drawing details it all a little bit more. The upper respiratory tract here can be a little bit overwhelming because there's so many labels here. They're labeling the sinuses, the tongue, the epiglottis, the tonsils, all kinds of things. The adenoids are listed on there, and they're all part of that upper respiratory system, but not all of them function as respiratory. For example, the tonsils and the adenoids really they have no respiratory function whatsoever. They have some immune function, but they're really not doing anything as far as respiratory. The epiglottis is kind of the same way. It doesn't really do anything for respiratory or respiration. What happens when an item, whether it's a food product or a foreign item, starts coming through into the back of our throat, our epiglottis kind of closes off the trachea like a garage door. So you know how like the old school garage doors kind of just flipped up and then down? Now they kind of roll up, but think of the old school ones that just kind of flipped straight up. The epiglottis is kind of like that, okay? It's open, but then when food stuff or a foreign material comes back to towards the back of the throat, as soon as it starts to feel it towards the back of the tongue, that epiglottis shuts in order so that nothing can pass into your airway. And thus then when you do that swallow motion and all of that muscle pushes food into your esophagus rather than into your airway. Of course, sometimes, you know, something gets past the goalie, right? And you then start choking, coughing hysterically, whether it's a drink or a food item. But when that happens, we call that aspiration, because you're aspiring, A-S-P, asp. You're aspirating, just means suction. You're sucking in something, but it's a foreign object that shouldn't be there. So, you know, there's lots of things we aspirate on purpose, but in this case, if we're aspirating a food item or a drink, a fluid that's not on purpose, then that's going to cause us this violent reaction of all of our muscles to like come together and try to spit that out. That way we don't inhale it in and cause a blockage in our trachea, which of course then ceases oxygen and we will cease to live shortly after. So I'm not going to go through all of these. Again, trying to maintain some sense of not going into too much detail on this. So kind of blow past the nose and the pharynx. No, I won't. So the nose is really good as a heat moisture exchanger. We should recognize that. It's our filter and it's our heater for gas flow coming in. Our lungs need body temperature and pressure, humidity, and heat. So it needs 98.6 degrees Fahrenheit, and it needs a humidity level that's 100% saturated humidity. So our nose, when we breathe in, helps us to do that. Now, when we breathe out, if we breathe out of our nose, it's doing the same thing. It's collecting the heat and the moisture that normally would be lost when we exhale, and it's trapping it. So the next time we breathe in, it lets it connect with our air and it heats it up and it humidifies it so it goes back to our lung and it keeps it healthy. Now, if we start exercising fast and I can't breathe through my nose fast enough because it's a smaller tube and there's more resistance, there's hairs and there's all kinds of bones up there, I'm going to start breathing through my mouth. Well, because there's no hairs and there's no bones like there is in the mouth, there's less surface area. It doesn't heat and moisturize as good as my nose. Therefore, I'm going to start drying out. And you'll notice that the more you breathe through your mouth, if you're a mouth breather at night, especially, you might wake up with cotton mouth. That's because you can't heat and moisturize that air that's coming through when you breathe in through your mouth. And so therefore, when you exhale, out your mouth, you're losing all that heat and moisture. If you breathe on a cold winter day into a face mask, it gets all wet if you breathe out of your mouth. But if you breathe out your nose, it doesn't, because the nose is capturing it, the mouth is letting it escape, and you're losing it. So the nose is extremely important for what we do. Pharynx, kind of the back of the throat area behind the tongue. We talked about that, adenoids and tonsils. Larynx, voice box, again, vocal cords, the epiglottis we mentioned, and as well as the trachea. Bronchus, bronchioles, again, those are just terms talking about the branches of the trachea that get smaller and smaller and smaller as we go through those 23 generations down to the actual alveoli themselves. So they're the airways that continuously get smaller until we actually get to the air space or the air sacs, which are the alveoli, where the actual gas exchange occurs. Each lung then is basically holding all of those things. So there's millions of alveoli within each lung. There's hundreds of different little bronchioles in each lung. Each lung has separate lobes and then separate segments within the lobes. So here we're looking at right lung has 3 lobes, left lung has 2 lobes. That's because the heart sits on the left side, and so it takes up space where the right lung's middle lobe should be. And so therefore it's not really a true lobe in that area. Diaphragm, we talked about, a huge muscle. It actually separates your thoracic cavity from your abdomen, but it's a huge muscle that pulls down in order to create that vacuum and that suction. And then the mediastinum is just a kind of a fancy word for that spot right in between the lungs, and it holds the heart and the aorta inside of it. So the mediastinum, it's a separate thing because you've got the pericardial lining or the visceral lining around the heart. It's kind of like a big Ziploc bag that the heart sits in, and it separates it from the big Ziploc bag that the lungs sit in. And so all of those organs are separated by really, really thin layers that are going to isolate them from each other, and also allow for when they move, when we're breathing back and forth, for them to slide smoothly past each other as opposed to grating back each other. Now, sometimes those linings can get inflamed by disease and other types of things, like if you're breathing super cold air, or if you got trauma, but usually disease will cause that, infections. It'll get inflamed, and then it will become less, it'll become less fluid and kind of actually become like grating on so here's my table. So like if I'm rubbing against the table, it has a lot of friction. And so you get that grating instead of that sliding. And we call that a pleural friction rub. And it actually would be very painful for patients. And it's something we can actually hear on a stethoscope as well. Combining forms of the respiratory system. So these are some major terms that you're going to be hearing a lot about within the respiratory system. And we've already mentioned the adenoids, again, but really more of a lymph type of system or an immune type of system rather than respiratory. It doesn't really have a respiratory function. But adenoid, remember that's different than adeno that we've learned before. So now it's adenoid, don't get those two confused. But alveole, so alveoli, alveolus, those are those air sacs or the air spaces. And then bronchi or broncho, bronchio, broncho, basically meaning the same thing pertaining to the airways. Diaphragm or diaphragmato, that's obviously your diaphragm. And then phren is the same thing. It refers to your diaphragm. So usually though, only time we're going to use phren is when we're talking about the phrenic nerve. So when we say the phrenic nerve, it's basically saying the exact same thing as the diaphragmatic nerve, but we don't call it the diaphragmatic nerve. It's called the phrenic nerve, and it is the nerve that innervates the diaphragm in order to tell it when to move and contract. If you have a diaphragmatic paralysis or a phrenic nerve damage, Christopher Reeves, the guy that was Superman in all those movies, the original ones, when he got into his accident, he became quadriplegic and actually had a phrenic nerve paralysis. So he had damage to his phrenic nerve. It caused his diaphragm. The muscle was still fine, It just was no longer getting the signal to breathe anymore. And so it didn't ever move. He had to get a pacemaker placed inside of his body that would send an electrical current to that muscle in order to make it move when it was supposed to. And so phrenic, just understand it does mean and associated with the diaphragm, but we don't ever call the diaphragm the phren or whatever. It's just, it's only referred to as the phrenic nerve. Epiglot for the epiglottis, again, that's kind of that safety trapdoor above the vocal cords. Laryngo, just relating to the larynx. Lob or lobo for lobes of the lung, and then naso and rhino, we know that's the nose from previous discussions. Pharyngo, the pharynx, and pleuro relating to the pleural space. Pleural space is outside of the lung, but it is a lining, so it's that visceral lining outside of the lung. So it's basically the Ziploc bag that the lungs sit in. It's that space, and we call that the pleural space. Pneum, pneumat, or pneumon, those all have to relate to the lung itself. Pulmon, again, they're just the pulmonary system in general. So pulmonary, pulmonologist, all relating to the lungs. Sept for like septum, sinus, again, sinuses, the basically hollow points in bones. Thorac or thoraco, just like thorax, your chest cavity. Tonsillo, tonsils, and trachea, obviously. Some combining forms that we've talked about some of these already, but atel and atello, we'll get into that later when we talk about atelectasis. Capped, meaning like CO2, capnography, things like that. Heme, hemato for blood. Muc for mucus. I just don't want to go through all of these because it kind of gets redundant, and I know you guys can look that information up in your text, but these are just some of the common ones that you're going to see in the respiratory system. Prefixes, the a and the an prefix, again, typically are meaning without. So when we say anaerobic, it's without aerobic metabolism. Endo is one that we'll often use when we're talking about the tubes that go into patients' tracheas to help them breathe. So an endotracheal tube. Tracheal meaning relation to the trachea, and endo meaning within, so within the trachea. That's the tube then that we are gonna eventually hook up to our mechanical ventilator in order to provide life support for those patients. U, the prefix, just basically means normal. So a word that we're going to see here in a little bit is eupnea. So kind of a really weird word, but it just means normal breathing pattern. Poly meaning multiple, and tachy meaning excessive. Quite a few suffixes as well. And these will make a little bit more sense when we actually combine them with the words, but a few that we've seen before, like emia, meaning a lack of, nia for breathing, graph, kind of self-explanatory there. So like a actual word, or not a word, but like a visual graph of something. So when we do a lot of stuff in our classes where we're graphing out breaths, so what we'd be looking at here, we call this a pressure waveform. And it's essentially a graph of how the pressure changes inside the lungs when we are mechanically ventilating them, which is really important. And then graphy would be the process or the science of making this graph. Meter, metry, things like pulse oximetry. You guys have probably all been to the doctor when they put that little clamp, the little clothespin on your finger, and it reads you your oxygen level. Okay, that's your pulse oximeter or pulse oximetry. That is, again, just checking your oxygen levels in your blood. And so that's where those suffixes are coming in. Some more of the regia, we've talked about that, meaning flow before. Scope, scopic, scopy. We do a lot of things with bronchoscopes. So basically video cameras or visualization of the bronch. So of the bronchioles, the airways. Spasms, bronchospasm, when the airways tighten up and get thin. So normally the air would be flowing through this channel, but when it bronchospasms or bronchoconstricts, it gets narrower. And that's when we start to see like asthmatic patients struggle. So bronchospasm, something that's typical for an asthmatic patient. Stenosis meaning narrowing, similar to Malaysia that we talked about yesterday or the day before. But Malaysia is that softening that causes a narrowing, whereas stenosis, something else is causing that narrowing. Some diagnostic terms, we mentioned the graph and the graphy and the gram. So we'll show some examples of those. We've talked about the tomy before, so incisions or ectomy. For excision, sorry about the typo there, that should be an E, excision, not excision, however it's listed there. But all of these tomes basically are surgical terms, meaning to cut or to remove via cutting somehow. So if you see that tome, in any case, it's something to do with removing. So now we kind of add a few of those things together and we see some of these word parts, but these ones are specific to disease. So all of a sudden, you know, we're looking at the very first one there on the left, itis. We know that's inflammation. We're starting to learn that. That's being a recurrent theme for us. So very common, we're going to see that. And as it applies to the adenoids, so adenoiditis in the back of the mouth, if they start to swell, and usually this just is in younger kids that we see this, then they possibly are going to need those removed, just like tonsillitis. Alveolitis would just be an inflammation of the alveolar space. Atelectasis is an incomplete expansion of the alveoli. And it's kind of a tough word to break down because what it actually means is alveolar collapse. So instead of the alveoli being full from breath to breath, between every breath, they collapse. Sometimes they pop back open, but then they collapse again. Other times they don't even pop open from breath to breath and they just stay closed. They're staying closed, oxygen and carbon dioxide cannot pass through it, and therefore it's not getting to the rest of the body either. And so it becomes a major issue. And atelectasis is something we deal with on a regular basis in respiratory therapy. Bronchiectasis, incomplete or an excessive dilation of the bronchi. So if we break down either of those two words using ectasis, we see that we have that ectasis meaning a dilation, and then atel meaning incomplete. So if we're saying, okay, ectasis means a dilation and ectel means incomplete, it would be an incomplete dilation, and that refers to the alveoli. Well, just saying it's an incomplete dilation doesn't really explain it enough. The term atelectasis as it's used in medicine means that collapse. Bronchiectasis, the ectasis, again, dilation, but then the bronchi, meaning the actual airway, is dilated on a permanent basis. Some other terms, you know, pneumonia, bronchopneumonia. We know what pneumonia means, okay, lung infection, and then broncho, dealing with specifically in that broncho space of the pneumonia, so the airway space. Try not to go through all of these, but just point out a few. LTB, laryngotracheobronchitis, that's a really fun word, but we've got the itis, we've got the bronch, we've got the tracheo, and we've got the larynx, and of course we've got a couple of combining vowels here that make some combining forms. Essentially, we have inflammation of the bronchi, the trachea, and the larynx. So you're inflamed from here all the way up to here. That's also known commonly as croup. And again, typically this is only a problem in infants, in children, so typically from like 8 and under. But it can be very severe in those kids, and this is when every year, usually about October through February, we kind of see these croupy kids, and they're the ones that are barking and they kind of sound like seals when they cough. So it's like I'm going to try to do this, but it's not going to work, but it's like a type of cough. And I can't do it justice, but when you hear a kid cough, you're just like croup, like you just know instantly what it is. And so you're like, okay, that kid's got a croupy cough. And they're like, what are you talking about? Well, they can't, he's barking like a seal. And they're like, what are you talking about? You're like, no, like that's, okay, never mind. And anyway, it's just a virus that's causing this problem, and it's very common. Lots of kids get hospitalized for it every single year. Crazy things as a respiratory therapist, when you're like walking through Walmart or you're out to dinner or something, you'll hear something or you'll see something and you'll just be like pinpoint it on, and everyone else kind of thinks you're weird, but you've got, you know, some medical thing for it, and you should really get that checked out. Anyway, moving on. So here's an example of like atelectasis that we'd mentioned before, and this demonstration here is basically showing you what happens when you have atelectasis, in that the lung should look like this, where it's fully inflated and it's filling up all of this area. Okay, so this would be pleural space that I just drew the squigglies through. But when the lungs do not fully expand, they're in incomplete dilation, atelectasis, then you get it collapsing like this to where it shrivels up, and therefore oxygen and CO2 are not passing through it. Problem with that, one, you've got no gas exchange, so that's an issue. Two, now you have a warm, moist environment with no gas exchange. Therefore, it's a great spot for infections to harbor and multiply. A lot of the time, these patients will get pneumonia as a result of this. So it's important that we expand that lung. And much of respiratory therapy is doing procedures on patients that are going to help them expand that lung so we can open it back up and not have that take place. The bronchiectasis is a little bit different. Notice that this lung is fully expanded. Okay, there's no decrease in the expansion like we saw before. What's trying to be shown here is that the airways themselves are being dilated, but on a continuous basis. And so essentially what happens after years and years of recurrent infections with these patients, the inflammation is bad enough that it causes the ability for the smooth muscle around those airways to keep the regulation or auto-regulation of the airway size, and therefore they get expanded and stay expanded. And that's what we see with bronchiectasis. Some more terms that are built from word terms, and these we can break down using any of the exercises through our book. But so the pneumato, again, a combining vowel, pneumatoceal. And you could go through any of these types of words and break those down. And so I do recommend that exercise, you know, any of these first couple of exercises throughout the chapter in order to take a look at these and practice that method that we learned all the way back in chapter 1, but now apply it to a new system. Okay, disease and disorder terms not built from word terms, and you'll see some acronyms listed in here. Some of the ones that will probably be familiar to you guys would be like asthma. Okay, we can't break that down. You just have to know what that means. And so sometimes that means looking it up at the bedside if you don't know what it means. I think we mentioned cor pulmonale at an earlier session, but that's basically right heart failure. So your heart, and this is anatomically correct in case you're wondering, that's what your heart looks like, is broken up into, I was kidding by the way, left atrium, left ventricle, right atrium, and right ventricle. And then you have your pulmonary artery that's pumped out of your right ventricle and goes to your lungs. Okay, so those are your lungs. And then you've got, from your lungs, it pumps back into the left atrium, down into the left ventricle, and then out of your aorta, which then runs down to the rest of your body and fuels your arterial system. So what happens if you have all kinds of different diseases that can cause high blood pressure in your lungs, in the capillaries of your lungs, then remember the right ventricle is pumping blood to your lungs. So if there's high pressure in your lungs, that's BP, high BP, that means this right ventricle has to work overtime and extra hard to try to pump through those tubes of high pressure. In that matter, like what happens if you regularly have to lift weights? You're going to get bigger, right? Well, if this right ventricle regularly has to work overtime in order to pump blood through the lungs, it's going to be hypertrophied. So meaning hypertrophy, meaning enlargement of the muscular size of that organ. And it's going to become really, really big. Well, you've probably all seen those guys like on Huntington Beach that are working out and they're just so big that they can't even put their arms down. Like they've lost flexibility because they're so muscular. Well, your heart can do the same thing. So imagine this is your right ventricle and it becomes so muscular that inside, like this is all muscle and this is where the blood is going to be before it gets pumped out. It can become so muscular that literally this area is so small that it can't move and it becomes less efficient at pumping blood out. Therefore, that blood backs up into the right atrium and then it continues to back up down into your lower extremities through your vena cavas, which are the veins that pump blood back to your heart. And that's when you get edema. Like you get people with their feet swelling or their knees and calves swelling because of edema, because their right heart cannot process the blood that's coming back to it. And we would call that cor pulmonale or right heart failure. The left-sided heart version of that would be called CHF or congestive heart failure. And it's caused by basically the same reason, except for when your aorta is pumping blood through the arterial system, if you have a high blood pressure in your arterial system, that is going to lead to CHF over time. And so both sides of the heart can start to fail and become ineffective at moving blood. And therefore, whatever's behind that portion of the heart is going to get filled up with fluid or blood. So behind the left heart is the lungs, and you'll get pulmonary edema. Behind the right heart is the rest of the venous system, and that's where you get dependent edema, like in your legs or your, your knees. Wow, that's a mess. Okay, a couple other terms that we looked at earlier was like croup, cystic fibrosis. You guys probably all have heard of cystic fibrosis to one extent or another, or know maybe someone that has had it or a child that has it. Deviated septums. I actually have a deviated septum. So if you look, like I'm looking at the camera right now to make my nose kind of straight, but if I actually look at the camera straight on, you can see how crooked my nose is. You guys see that? I don't know, not really, maybe. I've actually had a surgery to fix that because I was getting infections on a recurrent basis. And when I went into the doctor, he kind of checked me out. I couldn't breathe through my nose because my deviated septum was so bad. So they put me under, took a little hammer, broke my nose, tried to put it back into place. And so then I was that guy with the little mask and the nose thing for about 3 weeks. And this is the result. It's still not great. However, while he was in there, you have these bones inside of your nose called turbinates. And he went inside and like took a Dremel tool and just like rotored it all out and pulled it out. So now I can breathe exceptionally well, but it just doesn't look great. I don't have a Hollywood nose by any means. And that's my own fault. My nose was fine, but then stupid stuff in high school and I broke it a handful of times, and sports. I'll blame it on my stupidity, but most of it. Okay, moving on. Had a lot of epistaxis at that time. If you remember, that means a bloody nose. Some more terms not built from word parts: obstructive sleep apnea. You guys probably all know someone that sleeps with a CPAP machine, or maybe yourself has one. Pertussis, that's just another name for whooping cough. You probably have heard of whooping cough before, but that's pertussis. Pleural effusions, we talked about the pleural space. If you get fluid inside that pleural space, we've talked about edema. Embolisms are clots inside of your pulmonary arteries. Tuberculosis, you guys have probably heard of that disease. And then a URI, upper respiratory infection. Just kind of a quick little note on that. Most of the time, people come into the clinic and they say, I have this. And whenever a good provider hears their patient say, I've got a sinus infection, what they are hearing is, you have an upper respiratory infection. Because your sinuses are these open cavities that are inside of your bones. Rarely ever do you get a sinus infection. Almost always you have an upper respiratory infection, okay? It's same area, but different set of of symptoms. Now, if you've got this awful pressure headache and like you touch your forehead and it hurts and you're kind of like maybe sensitive to some light and you've got this awful drainage and fevers and it's been going on for a couple of weeks, then you probably have a sinus infection, okay? But if you just, you know, it's been 7 days and you've got some drainage and a lot of snot, you're sneezing and you're coughing, you're kind of hacking, and maybe you've got a fever that comes and goes, you probably have an upper respiratory infection, which will eventually lead to a sinus infection if we don't treat it. But just FYI, most people have upper respiratory infections and not actually sinus infections, but they do say that they have a sinus infection because they don't have the knowledge. Some surgical terms. So now we're just using those same word roots. So keep that in mind, those same word roots that we've already learned, but now we've just added something to them to make them a procedure. So we see a lot of these words, the adenoid and the bronch and the larynx, the lobes, the pleuros, but now we're adding that tomy to them, okay? Or plasty or ectomy. All of those other words that we know are surgical terms, and we know these are pulmonary terms, and now we're just adding them together. So like we mentioned in the first week, this really isn't anything new. Yeah, some of the pulmonary terms are new, but we're starting to see a lot of this stuff be reused and recycled. And so I hope that it's getting a little bit easier to work through each week as a result of that. When I say each week, each chapter, as we work through these. I'm not going to spend time going over this review question. It's in the text, but it's just asking, you know, which one is it labeled correctly? And one is obviously thoraco, meaning thorax, and the other one is tracheo, meaning the trachea. And when we're talking about draining fluid from the plural, that's taking place in the thoraco or the thorax, and obviously not the trachea. So very easy to get this one correct. Some diagnostic procedures in respiratory care. Radiography or chest x-rays are very important. We've spent a little bit of time talking about the AP or antero-posterior versus posterior antero, PA and AP x-rays and why that's important. Ultrasounds, nuke medicine, okay. Notice how I used the abbreviation nuke there instead of nuclear. That is something I had go to nuke medicine that we do use in the healthcare facilities. CT scans, no one says, I'm gonna go get a computed tomography or a computerized tomography scan. Nobody says that, it's just all CT scans. Same thing with MRIs. Endoscopy, laboratory, pulmonary function test, all other types of terms that are used. And you could see some of these are built using word terms. So endoscopy, going inside with a scope. Otherwise, like pulmonary function test, yeah, pulmonary, obviously that's there, but then function tests, those are just English words that we're using in order to build some diagnostic terms. Here you can see a whole list of those diagnostic terms that are built from word parts. So quite a bit of them, including some that are a little bit familiar, like oximeter or pulse oximeter, oximetry. Arterial blood gases is something that respiratory therapists hang their hat on. And I've mentioned that before. That's when you're taking the needle and you're going into the artery, as opposed to trying to just put an IV in or intravenous. We're actually going into the artery, because if we take artery blood, that's before it gets to the cells. So it's before metabolism. Veins are after metabolism, cellular metabolism. Arteries are before cellular metabolism. And therefore, if I can look at the oxygen in my blood before it gets to the cells and it's metabolized, I can see how well my lungs are actually working. And so that's something that we regularly are checking on patients. Some terms not built from word parts. Auscultation is anytime someone listens through a stethoscope. And so you see that term stethoscope, every time the doctor puts that on your chest, they're auscultating you. They can auscultate your lungs, they can auscultate your heart, they can auscultate your abdomen. Mechanics even have what they call a mechanics stethoscope, where they can, it's the same thing, it's a stethoscope, goes in your ears, and then it's got a rod on it, and they can put it on a certain part of your car, and they can hear very subtle sounds that are happening from your car in order to help diagnose it. That's auscultation as well, just obviously a different profession. Some more word parts, and these are complementary terms, but you can see a lot of these are using words we've already used. So capnia, CO2, dyspnea, meaning the nia for breathing, and dys meaning abnormal, so abnormal breathing. And here we see that eupnea. So normal breathing is eupnea. Now, hardly ever do we say someone's eupnic, but if we were going to be medically accurate, someone who's breathing normally is eupnic. Okay. Endotracheal, we already said, okay, yeah, that's inside the trachea. Capnia, more CO2. Hyper, meaning increased CO2. Hyperpnea, meaning a increased depth of breathing, as opposed to, let's see if it's on this next page, tachypnea, way down here. So we've still got that nia, meaning breathing, but the tachy, meaning increased rate, just like tachycardia, increased heart rate, tachypnea, increased respiratory rate, but hyperpnea is an increased depth of breathing, and hypopnea is a decreased depth of breathing, whereas a decreased rate of breathing we would call a bradypnea, and then if it's the heart rate, bradycardia. So the difference there between tachy and brady, hyper and hypo. Pretty much already talked about some of those and actually broken some up. Some terms that are complementary to the respiratory system that are not built from word parts. Again, some of these are somewhat built from word parts, but not all. So you see things like bronchoconstrictor, bronchoconstriction, bronchodilator, bronchospasm. Using some terms, so you know it's broncho, so you know what it's leading to the airways, the smaller airways. But then constrict and dilate, those are just those English terms that we're using. And here we see hyper and hypo being used, but then they're attached to ventilation. So those are not word parts. Crackles, typically if a patient has atelectasis, we're going to be able to auscultate crackles on our patient. So that's just kind of an example of how we would combine several medical terminology. And so you can start seeing like, okay, if I really start tagging on medical term after medical term after medical term, that's where we get like how Crystal said at the hospital, sometimes it's just like, I have no idea what you just said, right? And if nobody speaks medical language and you just say, okay, yeah, I'm going to auscultate and go through this process, and you're throwing 5 different medical terms on them, they're just like, they have no idea. And this happens a lot of times when you talk to family members at the bedside. They're asking you questions and you're explaining to them in your lingo how you would talk to another healthcare professional, and they're just like that was nothing. So we actually spend a lot of time in our program making the students explain things to each other in layman's terms. That way they can answer a patient or a patient's family member when they get asked a question. They can answer them in a way that makes sense to them and not just blow them away with medical lingo, right? It feels really good to be super smart and talk that way, but it's totally counterproductive if no one can understand what you're saying to them, and then all of a sudden you're not smart anymore. You're just, patting yourself on the back. Some other parts are terms not built from word parts that you may have been familiar with. So like nebulizer, you've probably seen those nebulizers, the little smoking medication devices that patients will use. Ventilator, that's a hot topic term right now. You can't turn on the TV without someone talking about ventilators. From a respiratory perspective, like it's great that we're talking about car manufacturers switching over and starting to build ventilators and the national ventilator stockpile and all of this kind of stuff. But the big problem is who's going to run those ventilators? It's great to have ventilators, but who's going to run them? And the reality is that respiratory therapists are the only healthcare practitioner who is didactically, so school and clinically competency-based and trained to manage mechanical ventilation. And so we need more respiratory therapists in times like these. There's a huge shortage. Actually, I have some alumni that are taking some traveling positions right now to go to hotspots like in New York and New Orleans, Michigan, things like that, where they're single and they're just hopping on a plane and they're going to go serve wherever they can serve because they need it. Okay, some abbreviations, and we're just about through. These are common, so ABG, arterial blood gas, AFB, acid-fast bacilli, ARDS, acute respiratory distress syndrome, CO2 for carbon dioxide, COPD, chronic obstructive pulmonary disease. That's a huge one that you see a lot. CPAP, okay, lots of obstructive sleep apnea users. So OSA, right? They use CPAP. So the OSAs use CPAP. And sometimes we talk like that too. It's just alphabet soup. It's like, okay, you didn't say one word. You just said a whole bunch of letters, and these, you know, that meant like 15 words, 3 sentences, and all you did was letters. Sometimes that happens too. But that stands for continuous positive airway pressure, and that positive airway pressure is what actually is opening the lungs or the airways open so that they are no longer obstructing during sleep. And so that helps to treat them. Other things we see like left lower lobe, left upper lobe, chest x-ray, influenza, interstitial pulmonary fibrosis, pulmonary embolism, and on and on. It just continues to go. The more we don't like to write words, the more we abbreviate them. Here's a good one. The patient is SOB, right? No, the shortness of breath, okay? We use it all the time, and it could easily be misconstrued, right? So you're talking about a patient in front of their family, and you talk about their increased SOB. Yeah. Sometimes you got to roll back the whole medical lingo just a little bit, but that's what we do. You guys have probably all heard MDIs, so metered dose inhaler. That's your puffer that the asthmatic is taking. SVN is the small volume nebulizer. That's the one that actually smokes, that you hook up to a compressor. BiPAP is also big in right now because it's bi-level positive airway pressure. And we have a lot of these machines that are good for NIV, non-invasive ventilation, meaning we can take this machine, hook it up to a mask on a patient, and ventilate them without having to put the tube in. Now, because we've got a ventilator shortage, everyone's saying we're going to take those devices and we're going to connect them to patients with tubes. And so we're using bi-level ventilators, which are typically these non-invasive, and we're hooking them up to patients that need a more intense ventilation and actually have a tube. So that's kind of a hot topic there. All right, I know that was a lot. Like, that was flying through these slides because there was a lot of them in a short period of time. The nice thing about it is, again, a lot of those terms, other than just those straight new pulmonary ones, we're just recycling the suffixes and the prefixes, and we're starting to kind of get some familiarity with that. So stay on top of your studies. If you have any questions, shoot me an email. Have a good week and weekend. Stay safe and healthy. Help people if you can. And I will see you guys next week.